Now we are going to genitourinary system.
A sagittal section of the kidney shows the cortex and medulla with blood vessels and the excretory ducts, including the pelvis and the ureter, and a histologic comparison of blood vessels, the different tubules of the nephron, and the collecting ducts. Top left, they have shown a gross image with the top adrenal gland, hilum, cortex, major calyx, minor calyx, medulla or the pyramid, sinus, pelvis, ureter, urinary bladder, urethra, and on the left side there is renal artery and renal veins, sir. Zooming
Super.
into the cortex, they have shown the urinary pole, capsular space, Bowman's capsule, efferent arteriole, vascular pole, distal convoluted tubule, arcuate artery, arcuate vein, afferent arteriole, glomerulus, vasa recta, loop of Henle, papillary duct, collecting duct, and on the top they have shown zoomed in proximal convoluted tubule and distal convoluted tubule, and at the
Super.
bottom left there is a thin segment of loop of Henle, thick segment of loop of Henle, and a capillary, sir.
The main thing you have to remember, the kidney is divided into cortex and medulla. So this is the cortex with the intervening columns. And you see glomeruli only in the cortex. See the adrenal here. The other name is, what is the other name?
Suprarenal gland, sir.
Super. And another important thing you have to remember, the adrenal spleen on the left side, the testes or ovary develop in one area embryologically. That's why you may see, and they move. Spleen move to the left hypochondrium, adrenal moves to the kidney, and testis and ovary moves down. And sometimes they may have remnant sticking. You can see adrenal with testes. You can see adrenal rest with ovary. You can see adrenal rest with spleen. That you have to keep it in mind. And whenever they go along with that organ, any disease affecting that organ can also affect. For example, you can get adrenal cortical adenoma, adrenal cortical hyperplasia, which is not used now in the testicular, paratesticular area. That's why you have to know the ectopic sites.
Point 1. Kidney, cortex, medulla, pyramid, and renal papilla. Panoramic view, stain, hematoxylin, and eosin, low magnification. Cortex and medulla is divided into two.
Only in the
glomeruli.
Super. And another thing you have to remember, the cortex and medulla is divided into by arterial system, arteriovenous system, and these are known as arcuate arteries because they are known like a arch, isn't it? Arcuate is like a arch, and from here the blood vessels go in the radiating way. Okay.
Sir, in cortex we have renal capsule, glomeruli, medullary rays, proximal convoluted tubule, base of pyramid that starts from medulla, collecting ducts, renal papillae, columnar epithelium. On the right, subcapsular convoluted tubules, proximal convoluted tubules, interlobular artery, interlobular vein, arcuate artery, and veins. In cortex, to the right, adipose and connective tissue of renal sinus, minor calyx and transrenal epithelium, interlobular artery, interlobular vein.
This is the whole section from the cortex to the pelvic system. Even though they have written it is lined by columnar epithelium, you may see urothelial type of cells also here. Or sometimes if there are any stones there, they will undergo squamous metaplasia. You can see columnar cells, urothelial cells or squamous cells depending upon the condition.
Figure 16.2, kidney, cortex and medulla, stain, hematoxylin and eosin, low magnification. One is proximal convoluted tubules, 2 is distal convoluted tubules, 3 is interlobular blood vessels, 4 is again distal convoluted tubule, 5 is the renal corpuscle consisting of glomerulus and the Bowman's capsule, 6 is straight ascending segment of the distal tubule, 7 is interlobar vein and artery, 8 is vascular pole, 9 is renal corpuscle, A is visceral layer, B is parietal layer, 10 is capsular space, 11 is glomerular arteriole, 12 is collecting tubules, 13 is capillaries, 14 is straight or descending segment of the proximal tubule, 15 is thin segments of the loop of Henle.
You can see proximal tubule and distal tubule. There is no problem in that. But to differentiate ascending limb of loop of Henle, descending limb of loop of Henle, on H&E wise, it's very, very difficult. Mainly, you have to remember rule of 4 in kidney. So, there are 4 major structures in kidney: glomerulus, tubules, blood vessels, and interstitium. You may ask me, where is the interstitium in the picture? There is no mention about interstitium. In a normal kidney, interstitium is not seen. All the glomeruli, tubules, everything is together, and you see the thin strands of some fibroblasts, some connective tissue in between the tubules, in between the glomeruli. These are all the interstitium. Normally, you don't see it. For example, tubular atrophy. Okay, the tubule undergo atrophy. Then you start seeing the interstitium. The blood vessels and interstitium, this is a nice strip of interstitium. We will concentrate on glomerulus. What do you all think? Is this correct or not? The Bowmen space is looking like a blind pouch here. The Bowmen space continues as the proximal tubule. So that you have to remember. There are 2 poles for the glomeruli. One is the vascular pole, where the blood vessels enter. When these enter, this is afferent arteriole. And when the blood leaves outside, this is known as efferent arteriole. This is the urinary pole, where the proximal tubules will come. So, how you have to draw correctly, whenever you draw the Bowmen space, you have to always draw the urinary pole. There is a reflection. Okay, and then you have to draw the blood vessels. And then inside there is loops of capillaries. So, this is how you have to draw. And another important thing is, at the junction of efferent and afferent arterioles, the distal convoluted tubule will be here. So, depending upon the content in the distal tubule, the arteries may contract or it may expand. It is taken care by the renin-angiotensin system. So, this is also known as juxtaglomerular apparatus. Afferent arteriole, the epithelium of the distal convoluted tubule, and the efferent arteriole. It's very difficult to identify H&E unless you are very lucky to see that. This is the Bowmen space, okay? So, I will fill it up urine here. Urine is supposed to be here. See, kidney is a wonderful organ where it intakes blood and outputs urine. I know urine won't be this yellow in color. It is not jaundiced patient, but I just want to. So, it continues into the proximal tubule, and again the epithelium will be there in the proximal tubule. So, the Bowmen space is lined by epithelial cells, and as you know, there are 2 layers of Bowmen's space. The outer side layer is known as parietal epithelial cells, and inner space is known as viscera and visceral epithelial cell. Parietal epithelium will be very flat. So, how you have to draw the visceral epithelium? You have to draw cells like this. These are the food processes, and then the epithelium will be here. And let us draw the nuclei. So, this picture, all of you, please have a idea of that. So, again here there are 4 things you have to remember. There are 4 structures you have to identify in the glomeruli. The capillaries, Bowmen space bound by visceral layer and epithelial layer. And there are 2 poles. One is vascular pole, other one is the urinary pole. In the vascular pole, you have the juxtaglomerular apparatus.
Kidney cortex, juxtaglomerular apparatus, stain hematoxylin eosin, medium magnification. Distal convoluted tubule, glomerular capillaries, glomerular arteriole, juxtaglomerular vascula densa, proximal convoluted tubule, interlobular vessel, venule, and arteriole. Then collecting tubule, basement membrane, glomerular capsule, parietal visceral layer, and the urinary pole, afferent glomerular arteriole, capsular space, proximal convoluted tubule, distal convoluted tubule.
This is the urinary pole, and this is the vascular pole. And in the vascular pole, you see the juxtaglomerular apparatus. This is the parietal epithelium, which is very flat. You can see that here. And the visceral epithelium, they have not drawn it, and they will look like food processes like that. If you draw this area here, we are drawing the basement membrane of the capillary loops. This is the another loop. What cells I am drawing? These are endothelial cells. These are the nuclei of the endothelial cells. This is the basement membrane. And the food processes, the cells with podocytes, they will come above. So these are the podocytes. These are all the food processors, and the cell will be like this. What is this cell I am drawing now, ma?
Parietal cells.
Super, ma. What cell I am drawing now? I know I am going into the picture now. Parietal cell continues as a proximal tubule. So to identify the structures, this is the capillary, and this is the basement membrane. This is the podocyte, or the other name is visceral epithelial cell. This one is parietal epithelial cell, and this is the proximal convoluted tubule. This is more for theory. You may not see it in this detail in a light microscope. There are a few more things in between. What is the thing in between the capillary loops? That is the mesangium. The yellow color is mesangial matrix, and I am drawing cells like here. These are known as mesangial cells. The diseases of the glomeruli, again you have to remember 4 things. Number 1 is capillaries. Number 2, basement membrane. Number 3, the parietal and visceral epithelial cells. And number 4, mesangium. In the 4, you have the matrix and the mesangial cell, 4A and 4B. In the Bowmen space, you have 3A is visceral epithelium, 3B is Bowmen space, 3C is parietal epithelium. And another thing, we see the kidney with 4 stains. Number 1 is HNE. Number 2 is PAS diastase. PAS highlights the basement membrane. That's why we want to see that. Number 3 is, I will put trichrome. And number 4 is Gomery's methenamine silver. Why we have to know? So the glomerular diseases may be diseases of the capillaries, diseases of the visceral epithelium, parietal epithelium or visceral epithelium, diseases in the Bowmen space, for example, crescentic glomerulonephritis, and diseases in the mesangium. I am going to draw highest power of this region. This is endothelium. This is basement membrane, and this is the podocyte. And please remember the other name of podocyte is visceral epithelium. And in between the capillary loops, so this is mesangial matrix. It's mesangial matrix, MM, mesangial cell. You know the immune complexes get deposited. Deposit can happen here. Deposit can happen here. And the deposits can happen here. So there are 4 sites that deposits can happen. The deposit here is beneath the endothelium. So it is sub-endothelial. This deposit is known as?
Membranous deposit.
Super, membranous deposit. Okay. And what is the name of this deposit here, ma?
Subepithelial.
Because it is beneath the epithelium, the podocyte, that's why it is subepithelial. And what is the last deposit here, ma?
Mesangial deposit.
The immune complex, it may be immune complex deposition or only antibody deposition. That depends upon whether that antigen is belonging to the kidney or the antigen is also coming outside along with the antibody, antigen-antibody complex. Okay, that we will see it in 1 minute. So the deposits can be again 4. It can be subendothelial deposit, it can be membranous deposit, it can be subepithelial deposit, or it can be mesangial deposit. Subendothelial, for example, we will go for SLE. Membranous, we will go for dense deposit disease, DDD, okay, where there is membranous deposit. Subepithelial, the best is, remember we used to call it post-streptococcal. What they are now telling, it is associated with other infection also other than streptococcal. Okay, so they change the name as post-infectious, and then they find out it is not only post-infectious, it can happen even during the infectious process. That's why it is now known as acute infectious glomerular nephritis, AIGM. Okay, previously known as post-streptococcal glomerulonephritis, then it will become post-infectious glomerulonephritis. But now we are not using both these terminologies. We are using the term AIGN. Okay, AIGN classically produces subepithelial deposits. And mesangial deposit, the best known example is IgA disease. The site of deposition depends upon two things. One is the size of the immune complex, and second one is what are the charges. Is it negatively charged? Is it positively charged? Like that. This is a antigen antibody complex. Here the antigen can be intrinsic, that is present inside the kidney itself. Remember, this is the kidney. Or the antigen can be outside kidney, and then the antibody comes and joins there. So it can be an antigen antibody complex formed outside the kidney, where the kidney is an innocent bystander. No disease in the kidney, but the antigen antibody complex is formed outside and it is deposited in the kidney. For example, SLE. Whereas in some diseases, the antigen is formed part of the kidney and the antibody comes there. The antigen antibody complex is formed in the kidney. The best example is Goodpasture syndrome. We already saw the basement membrane is part of the antigen and it attacks the anti-basement membrane antibodies. So this you have to remember. And the deposit is an antigen antibody complex. The antigen can be intrinsic or it can be extrinsic to the kidney. That is very, very important. And in that itself, you have to know again, there are four things in the kidney. What are the things we use for diagnosis of renal disease? One is light microscopy. Two is histochemistry, like what I told, PASD, trichrome, Gomery's methenamine silver stain. Three is IF, immunofluorescence. Fourth one is electron microscopy. When the antigen is part of the kidney, then we are talking about IF, because IF only will help to see whether it is intrinsic or extrinsic. In IF, it will have a linear pattern when the antigen is intrinsic to the kidney. When the antigen is extrinsic to the kidney, it will have a granular pattern. What happens in the immunofluorescent microscope? The background will be very dark, deposits by green color, and these deposits can be linear. Linear means it's like a membrane, or it can be granular, like a line. This is linear. Granular means it will be like this. So this tells you what is the pathogenesis. The linear pattern is Goodpasture syndrome, and the granular pattern is acute infectious glomerulonephritis.
Figure 16.5, kidney scanning electron micrograph of podocytes. That is visceral epithelium of glomerular or Bowmen's capsule surrounding the glomerular capillaries. We see primary processes, pedicles, again primary processes, proteinaceous debris, filtration slits, cell body of podocyte and pedicles.
Super. And before going further, the electron microscopy itself, it can be either scanning electron microscopy where you see the surface, or it can be transmission electron microscopy, you see beneath the surface. That's why the figure 16.5 is scanning microscopy. It shows the surface. And you see the leaf-like pattern, and each leaf-like pattern is the podocytes.
Figure 16.6, kidney transmission electron micrograph of podocyte and adjacent capillaries in the renal corpuscle, 6,500 times magnification. We see filtration slits, pedicles, nucleus of podocyte, capsular space, pedicles, lumen of capillary, erythrocyte, lumen of capillary, leukocyte, nucleus of endothelial cell, cytoplasm of podocyte, primary process of podocyte, basement membrane of capillary.
I am going to draw the deposits here, and you have to tell me what is the location of the deposit. What is the deposit here, ma?
Subepithelial, sir.
Next.
Membranous, sir.
Super, ma.
Subendothelial, sir.
Very good, ma. Mesangium is not there in the picture. Okay, so that's why I'm not able to draw. Now we are going to deal with the tubules. Tubules, you should be able to differentiate proximal and distal convoluted tubules, but here they are more like a medulla. Medulla won't have that many proximal tubules, only cortex will have a high number of tubules. We will see it here. This is one type of the tubule, this is the other type of the tubule. More pink cytoplasm is more proximal tubular. Other thing you have to remember, the lumen will be irregular in proximal tubules, lumen. Whereas when you see the distal tubules, the lumen will be very irregular. And the distal tubules are lined by cuboidal cells, whereas the proximal tubules are lined by more columnar cells. And when you see what is the other feature that may you helpful, ma? Remember, Meryl, we talked about one of the character of the proximal tubule before.
Basal striations, sir.
Can you see the basal striations in the thick segment of loop of Henle?
Yes, sir.
So it's easy to differentiate proximal tubule and distal tubule by HNE itself. And proximal tubule is the workhorse of the kidney. That is the main cell that is working very hard in the kidney. And they will also have brush border appearance because they have to absorb what are all needed in our body. They have to excrete what is not needed in our body.
Figure 16.7, kidney medulla, papillary region, transverse section, stain of hematoxin and leucine. On medium magnification, they are seeing straight descending segment of proximal tubule, venules, papillary ducts, capillaries, thin segment of loop of Henle, straight descending segment of proximal tubule, straight ascending segment of distal tubule, thin segments of loop of Henle, capillaries, straight ascending segment distal tubule, straight descending segment of proximal tubule and connective tissue.
You remember proximal tubule, distal tubule, collecting ducts, we can identify more cuboidal cells, and then interstitium with blood vessels.
Figure 16.8, kidney medulla, terminal end of papilla, longitudinal section, stain of hematoxin and leucine. On medium magnification, you are seeing venules, renal interstitium, connective tissue, thin segment of loop of Henle, capillaries, thin segment of loop of Henle, papillary ducts, and covering epithelium.
What do you think about covering epithelium, ma? Do you want to give any other name for that?
It's like a urothelial cell.
Very good, ma. You see more interstitium in the medulla. Just imagine this picture and then I will go to the cortex. You never see that much of connective tissue in between here. Here there is no connective tissue you see. But if you go to high power, in between the tubules, these are all the interstitium. Very difficult to appreciate in the cortex in a normal kidney. The pelvic-calcial system, the lining epithelium is urothelium. They may give rise to urothelial carcinoma.
Kidney, ducts of medullary region, longitudinal section, stain hematoxylin and eosin, 130 times magnified. Collecting tubules, thick segments of the loop of Henle, thin segments of the loop of Henle, vasa recta.
Ureter.
Urinary system, ureter, transverse section, stain hematoxylin and eosin, low magnification. Adipose tissue, circular smooth muscle layer, longitudinal smooth muscle layer, lumen of ureter, lamina propria, arteriole, transitional epithelium, venule, adventitia, adipose tissue.
There is one layer missing here in ureter.
Submucosa also.
Yes.
Section of a ureter wall, transverse section, stain hematoxylin and eosin, medium magnification, arteriole and venule, circular smooth muscle layer, adipose cells, adventitia, surface membrane, mucosal fold, transitional epithelium, longitudinal smooth muscle layer, lamina propria.
Super. See the lamina propria sitting directly over the muscle layer. Okay, so no submucosa there.
Urinary bladder, wall, transverse section, stain hematoxylin and eosin, low magnification, smooth muscle bundles, interstitial connective tissue, serosa, consisting of connective tissues, mesothelium, blood vessels, mucosal folds, transitional epithelium, lamina propria, blood vessel in lamina propria. Urinary bladder, contracted mucosa, transverse section, stain hematoxylin and eosin, medium magnification. Smooth muscle bundles, venule and arteriole, lamina propria, transitional epithelium, outer plasma membrane, binucleates.
Umbrella cell. When you see a urothelial tumor, they do cystectomy when the muscle is involved. I have drawn 3 tumors, blackish tumors here. So the first one is non-invasive papillary urothelial carcinoma. Whereas here, papillary urothelial carcinoma with lamina propria invasion. Whereas here, it is papillary urothelial carcinoma, muscle invasive. Whenever there is an invasion, you have to see whether it is a lamina propria invasion or muscle invasion. And when it is muscle invasion, they have to go for radical cystectomy. Whereas in lamina propria invasion or non-invasion, they will go with more conservative, bladder conservative therapies like intravesicular BCG or intravesicular mitomycin. And whenever muscle is not there in the biopsy, we have to mention papillary urothelial carcinoma high grade, muscle is not available in the biopsy to evaluate. Usually what they do, they take a biopsy from the tumor, and after taking the biopsy, this will come as specimen A. Then they will take another biopsy from the bed of the lesion, that will come as B. So you have to take A and B. And some of these arteries can have some muscle bundles there. That muscle, but this is in the lamina propria, and this muscle bundle should not be mistaken as the muscularis propria or the detrusor muscle. And remember, I told you there is one ISC that will help to differentiate this muscle bundle in the lamina propria from this muscle bundle in the detrusor muscle. Smoothline will help you to differentiate. Please consider radiology is part of gross pathology. Then only, for example, you have a bladder, go and see the radiology, muscle invasion there. Then you concentrate more on the area where there is muscle invasion. We will show some tricks with the fingers, okay? This is like food processors sitting on the basement membrane. But it is not that simple. This is one podocyte. This is another podocyte, and they will sit together like this. The cortex, all the tubules and glomeruli will be sitting like this. You don't see the interstitium. But whenever there is a tubular atrophy, can you see the space? Imagine these fingers are tubules. This is normal cortex, okay? But this is tubular atrophy. Can you see the interstitium? The empty space is the interstitium. Another very important thing I forgot to mention, in the glomeruli, you have to count the nuclei, okay? And usually it will be 75 to 100. So glomerular diseases can be divided into hypercellular lesions or hypocellular lesions, okay? The hypocellular lesion present with proteinuria. The best example is membranous glomerulonephritis, where there is thickening of the membrane, but the cells are not increased in number. In fact, they will look like they are less in number because of the membranous disease. So it is hypocellular, and it is present with nephrotic syndrome. Nephrotic, that means proteinuria. Hypercellular present with nephritic. Hematuria you will start seeing, RBC cast, WBC cast will be seen. AIGN is hypercellular. Because of that hypercellularity, they will present with nephritic hematuria. Okay, membranous glomerulonephritis is hypocellular, so they are present with nephrotic proteinuria.